Good evening, everyone, and welcome to the webinar on the theme ICML 2025 Lymphoma Updates. It gives me great pleasure to invite our Program Director and Chairperson, Dr. Reena Nair, Senior Consultant in Clinical Hematology and HOD Department of Medical Oncology, Tata Medical Center, Kolkata. Over to you, ma'am.
So, thanks a lot for organizing this CME, if I can call it. Hodgkin's lymphoma has always been at the forefront of changes that have happened in oncology. And not only in hemato-oncology, but for many solid tumors, it has also been a prototype. It has been the first, let's say, disease which actually could be cured easily, and that is more than 80 years back. Then we realize that it is so curable that we don't need to create any toxicities. And we have drastically come down in the amount of toxicities that we create to cure these patients. And now it has become absolutely imperative that a hemato-oncologist treats the patient with the best interest of quality of life and long-term survival of these patients. So despite the fact that it has been one of the most curable diseases for more than 40 years now, things keep changing every 2 years. And today, I think in the ICML discussions, we will have a lot of discussions on what's new and how do we reduce toxicity further and make these patients just as curable as they have been. So with that, I think we'll go on to the first presentation by Priyanka, and that will be on the new drug or the new kid on the block, which is no more new, more than 5 to 7 years old now. And we will ask her to give her talk on frontline management with brentuximab now. Priyanka, all yours.
Yeah, good evening, ma'am. I suppose. Yeah. Very good evening, ma'am. It is so nice to see you on the webinar. I think my camera is not good enough, but I'll be sharing my slides from my end. Are you sharing the slides from your end?
Ma'am, you can share it from your end, ma'am.
Just a minute, yeah. Is it visible?
Yes, Priyanka.
Yes, ma'am.
Yeah. So thank you, Reena, ma'am. And I think when I first used this drug, I asked Reena ma'am about it because it was about a transplant patient, allotransplant patient had relapsed following an autologous transplant. And that was my first experience with this drug in a relapsed refractory Hodgkin lymphoma. So I think it's so nice to see Madam over here chairing the session. So thank you, Takeda, for us and getting this drug to us also, because I think as we move ahead nowadays with the targeted therapy and drugs which are targeting the molecules with less of toxicity and making it available for the patients who are frail or ineligible to take the drugs or the chemotherapy, the conventional chemotherapy, it has been definitely a breakthrough for the treatment regarding these patients. So this is my disclaimer. The slides have been shared by Takeda. So what is the thing which we are going to next talk about in the next 20-30 minutes will be regarding the challenges in the treatment of stage 3 and 4 Hodgkin's lymphoma with brentuximab, that is ADCETRIS, the drug, the molecule which Takeda has brought us with. And this is the first-in-class CD30 targeted therapy, the Echelon-1 study in the frontline Hodgkin's lymphoma, and that was how it got approved by the US FDA, bringing about a PFS as well as OS benefit. So, and to remember is that in the early stages, sometimes I find there are some referrals to us when the patients have already been given this drug in the frontline setting for the stage 1 and 2 non-bulky disease. But it is to be to take a note of it that it is only meant as a frontline therapy for the patients who are in the stage 3 and 4 or the advanced stage of Hodgkin lymphoma. So with that, we can see the incidence of Hodgkin lymphoma It has a bimodal age of distribution. We all know there are two peaks, one in the 20 to 30 years age, and the other one is more than 75 years of age. So mostly when, even in India, when we look into this, the 20 to 34 years age, they are quite fit. Most of the patients, they take ABVD very well, but it is definitely a challenge for the patients of more than 75 years, where we have some cardiac comorbidities in the patients. And as we know that lymphomas are very sensitive to the alkylators, and there the doxorubicin is a challenge to us in delivering this drug and bringing about a cure to the patients, which, as we counsel the patient, it is not a palliative form of therapy with an ABVD or be it a BIACOP. So these are the patients whom at 75 years of age, we try to sort of a palliation therapy. But with the advent of this drug, I think as a upfront, we are able to even provide a cure to these patients. So whatever is the global incidence, I think in India also we have a similar incidence, though we have more of mixed cellularity and less of NLPHL or the nodular sclerosis form also. The more amount of EBV driven Hodgkin lymphoma we find. So survival outcomes for older patients with Hodgkin lymphoma are inferior as opposed to the younger ones. Just as we said, less than 60 years, you can see a 5-year OS of approximately 90%. So that is how, when a patient of Hodgkin lymphoma is diagnosed with us in our clinics, it is like a matter, it's not such an aggressive disease, just like the way we see leukemia and we counsel so aggressively. But beyond 60 years, definitely yes, 58% or 60%, we are not very happy with the figures, as there is a difference of approximately 30% across these two age groups. So treatment, if you look into, just a minute. Yeah, if we look into the treatment failure, just a minute, yeah. I don't know why the first slide in my, yeah, yes. Treatment failure remains a risk despite high cure rates with multi-agent frontline chemotherapy for advanced stage Hodgkin lymphoma. So if we look into more than we just talked, approximately 80% of the patients with Hodgkin lymphoma will have a success, and it is more common in the young patients. But then 5 to 10% will have a primary refractory disease, and they are the ones actually where it's difficult to counsel that from a regimen which is quite cheap, affordable, and tolerable. But in those 10% or 30% who experience a relapse after an initial response, how to go about and how to counsel regarding a definitive form of therapy. And mostly we counsel about cure with a autologous stem cell transplant. But patients who have a primary refractory or a relapse within the first, early relapse within the first 6 months or 1 year, most of them are chemo refractory, and there is where, and these are the patients where we actually find a role of targeted therapy to get the patient into a complete metabolic response by a PET adapted therapy and by a PET adapted response, and then move on to an autologous stem cell transplant. So among patients with the advanced Hodgkin lymphoma treated with the first line ABVD, you can see that up to 30% will progress or die within next 5 to 7 years. So these are the challenges or the unmet needs for treatments, and that is what we are looking into, how to decrease the relapse rate with a more amount of cure when the patient is given a frontline therapy. So the standard multi-agent chemotherapy regimens can be associated with high rates of short as well as long-term toxicity. So as we see that this is a bimodal age distribution is there for the Hodgkin lymphoma, patients between 15 to 30 years of age, if they get cured, but ultimately if there are some sequelae to the regimen which they have received, such as the fertility issues, endocrine dysfunction, like hypothyroidism developing mostly in the young adults, pulmonary toxicity, bleomycin induced, and acute treatment related toxicity. We have had patients who have undergone cardiomyopathy because of the exposure to the doxorubicin, anthracycline induced, just as I mentioned. Secondary malignancy, long-term effect like radiation therapy increases the secondary malignancy. Breast cancer increases the risk after the doxorubicin, and sometimes even we give mediastinal irradiation to some of the patients who have a bulky disease, and initially they present with SVC or that sort of complication. And death, definitely, when there are some sudden cardiac deaths also we find in patients who are undergoing this chemotherapy. So how to reduce this toxicity in a highly curable lymphoma, that was also one of the main intent when the patients were getting cured with ABVD like regimen. So treatment for Hodgkin lymphoma is almost always provided with a curative intent. And in spite of the fact that we have stage 1 to stage 4 disease, but irrespective of the stage, I think it is always a curative intent for the patients who are diagnosed with this disease. And treatment like ABVD is associated with the event-free survival and failure-free treatment-free rates of approximately 62 to 73% over 4 to 7 years. So this is even quite significant. Patients with cancer but still having a very good EFS of approximately 70% over 7 years. Definitely a disease which need to be assessed so that the toxicity are less with the treatment regimens we are giving. So rates of cure per line of treatment, 80% frontline therapy, 50% with autologous stem cell transplant consolidation, and you can see over here the relapsed and the transplant ineligible approximately make up less than 50% of the patients with a median OS of less than 3 years. So the challenges which we face and the challenge is to increase the number of the patients who achieve long-term remission, definitely by reducing the toxicity and the long-term side effects we just talked about in the younger and the elderly, how we have to see. We talked a lot about the younger group of patients, but for the elderly also, approximately 1/3 of all those with Hodgkin lymphoma in the older patients, still there is a strong survival predictor. And if we provide a regimen with less toxicities, the therapy delays and dose reductions are reduced, and therefore the patient can get a sufficient amount of therapeutic dose exposure to the chemotherapy and have a good response with a curative intent. So in India, what we have found in frontline Hodgkin lymphoma, the ADCETRIS plus AVD is an approved regimen in the frontline setting along with ABVD and PIACOP in the patients who are high risk or the patients who have stage 3 and 4 Hodgkin lymphoma. But if you have gone through now, the Nivo is also approved as a frontline therapy with ABD in the stage 3 and 4 or advanced stage Hodgkin lymphoma, and Bricard has also been approved. But these two are not yet the ones which are into practice yet to be approved as a frontline therapy in India. Because if you want to have a support for these patients to get, these are costly drugs, you need to have a patient assistance support. So if you're giving this as a frontline therapy, I think we will not be able to do. But having said that, there is a very beautiful article where they have compared the outcomes of Nivo AVD along with Bricard, and Nivo AVD is approximately 90 to 95% cure rate or a CR/CMR, complete metabolic response, with the Nivo group. So that is something I think a very good way of having a regimen at the front line so that you do not have relapse or primary refractory disease. So this is yet to be approved as a frontline therapy. So whatever we have as of now in India is ADCETRIS as well as along with the combination of AVD. So what defines success in Hodgkin lymphoma is, as I said, curative intent has always been the goal for the treatment. So that increases the overall survival and it aligns better with the OS-driven decision making. And that is one of the reasons why ADCETRIS has been approved with AVD as a frontline therapy, because it has shown that there is a benefit in both PFS as well as OS. So what are the challenges in the treatment when you give the patient BV? So the Echelon-1 trial actually, which got the approval. So this is the drug. CD30 expression has to be looked into, and we know that Hodgkin lymphoma is a CD30 positive lymphoma. Along with that, we have other T-cell lymphomas like the ALCL, the PTCL subtypes, and the CTCL, where, and apart from that, the B-cell lymphomas like the DLBL, it can also have a CD30 expression and it can be used as a salvage therapy for those patients. So how the drug acts, we all know almost, binding and internalization of the drug. And then there is a release of this MMAE, that is trafficking to the lysosome. And then there is the microtubule disruption. it is almost the same as that of the mechanism by the vinblastine or the vinca alkaloids, as a result of which we have some neurological toxicities or peripheral neuropathy associated with the drug, and therefore the combination with V or vinblastine does not actually has a good, actually deteriorates the peripheral neuropathy, as both the drugs contribute to it, and then ultimately there is a cell death. So the Echelon-1 study in the frontline Hodgkin lymphoma, this is a study, actually it was published in 2018 in NEJM, where you can see they have taken up the patients more than 18 years untreated, that is 9 patients of classical Hodgkin lymphoma stage 3 and 4 with a performance status of 0 to 2, and the IPS list score was low versus intermediate versus high. Most of them were in the high risk group. 6 cycles of ABVD. There was randomization between 6 cycles of ABVD and the combination of BV with ABD. And it was both a day 1 and day 15 infusion with 1.2 milligram per kg IV dose. At the end of 2 cycles, the interim PET was assessed as it was shown in the RRHL trial. And at the end of the therapy, where the 6 cycles also, it was assessed. And then follow up every 3 months for approximately 3 years, then every 6 months until the study closure. So primary endpoints were median PFS, and it was reviewed by the interim review committee. And the secondary endpoint was alpha controlled event driven OS. So OS benefit was to be noted in this as opposed to the ABVD. So disease characteristics, you see the number of the patients almost equally distributed in both the arms. And the other disease characteristics like stage 3 and 4 IPS, ECOG, almost it was similar across the arms. So if you look into here, you can see that the BV-ABD demonstrated a PFS benefit versus ABVD, and the primary endpoint probability of the 2-year modified PFS was better in the BV-ABD arm as compared to the ABVD arm. There was a 23% reduction in the modified PFS with the BV-ABD compared with ABVD. So this was the independent review committee's assessment. And the probability at 6 years and at 7 years, that is a long-term follow-up. There also it showed that BV-ABD reduced the risk of disease progression or death by 32% compared with ABVD. So if we look into the ABVD also has a response rate of 80%, and BV-ABD also has a response of approximately 80 to 85%. But at the long-term follow-up, the probability of the PFS was 32% better with the BV-ABD as compared with the ABVD alone. So this was a statistically significant difference which favored the BV-ABD compared to the ABVD arm. So we talk about a lot regarding the PFS, but at the end, when we look into most of the trials where there is a 2-arm, there is a randomized trial, the OS benefit is not well established in a number of the drugs, but this was a drug which was actually showing a OS benefit as well, and this was one of the primary endpoints for this drug. And as we can see over here, over a longer period of follow-up, actually the OS benefit is more pronounced, or you are able to interpret that. And here you can see there is a 41% reduction in the risk of death as compared to ABVD. So there is a significant improvement in the OS at 6 years and 7 years. So this was across all the groups. They wanted to say that patients who were less than 40, more than 60, stage 4 disease, across every subgroup, there was an increase in the OS and reduction in the risk of the death. So this was a Connect study where 91% of the healthcare practitioners considered that overall survival as the primary factor in the frontline therapy decision in the stage 3 and 4 classical Hodgkin lymphoma. And you can see that in this study also, the overall survival was approximately 91%. So across the other things like the adverse events, the PFS, the complete response, they were almost comparable as compared to the Echelon-1 study. So here again, they said that the first choice in the treatment frontline for stage 3 and 4 classic Hodgkin lymphoma across the patient profile, there was a benefit when the new drug was added to the ABD arm. So in frontline Hodgkin lymphoma scenarios where BV-ABD should be preferred. So with a good follow-up of approximately 7 to 8 years, patients with the advanced stage who received this BV-AVD combination showed a OS as well as a PFS benefit versus the EBVD, and there was decreased amount of death as well as toxicity. So summarizing the Echelon 1 study, OS advantage has seldom been demonstrated in most of the other drugs. ABVD is still widely considered standard of care in frontline advanced Hodgkin lymphoma, but since there are significant toxicities with bleomycin and the anthracyclines, approximately some of the patients are not able to tolerate a regimen, and approximately 30% or one-third of the patients will have a refractory disease or they may relapse early. So in those cases, there is an option to have BV-AVD as a frontline therapy or a more intensive therapy. And the 7-year follow-up data has shown that there is an OS advantage across all the high groups or the higher stage disease, and there is a better adverse event or a tolerability effect as with the BV-AVD arm. And the second malignancies which we actually look into when the patient have crossed the 10-year survival in the younger patients especially, the BV-AVD has shown that there are fewer second malignancies as compared to the ABVD arm. So with that, I think we have had some experience with the drug, not only in Hodgkin lymphoma, but also in the T-cell lymphomas. And I think it is a very tolerable drug and fewer side effects. But yes, in the elderly, we find pretty good number of peripheral neuropathies. And that is something which we need to take care of. And there is some drug dosage adjustment to allow the tolerability of this drug and continue the patients with the therapy and complete the cycles. So with this, I hand over back to Reena Nair ma'am to continue with the next session.
Since you've done well with time, maybe we can have a few questions. And while I wait for questions in the chat box from the audience, I'll ask you a couple of questions. How easy is it to give brentuximab with ABVD or AVD?
AVD.
Yes.
Just as I said, madam, we have used it in 1 or 2 patients who were elderly, but peripheral neuropathy for a PTCL NOS patient, actually, the patient presented with hemophagocytosis. And it was a very tough time. We had to take him out of that with the IVIG and steroids. And then later on, just started with 10 mg Dexa BB, a little bit of stabilization. Approximately 15 to 20 days later, we were able to start with BB. So giving the drug infusional toxicity, we do not find much. In the OPD also, it can be given very well. But yes, regarding the peripheral neuropathy, as I said, in the elderly, they have diabetic neuropathy. Then they have this, when you're giving AVD, the vinblastine itself is there. So I think peripheral neuropathy is something you need to look into also. And it is not also very easily given because there are some amount of neutropenia also. So these patients definitely require growth factor to get their counts into normal so that they can have the day 15, the day 15 dosage as well.
Yeah, I completely agree that it is, we would have loved it to be like the rituximab monoclonal antibody. This is not a monoclonal antibody as simple as that. There is a lot of neutropenia, and one has to understand that growth factors is compulsory in these patients. And we must not take a chance. They come with febrile neutropenia and they get infections very easily. So during treatment also, even in the young patients, you have to take a lot of care. And just as rightly Priyanka has said, peripheral neuropathy and painful peripheral neuropathy is a problem, again, even in the young patients without comorbidities like diabetes. And so you have to be careful. Priyanka, any thoughts on the Echelon 1 trial? Could that have been done in a different manner and a little better?
Madam, these are usually, pharma-driven trials. So they choose the patients very, the intent is to show that the patient are able to complete the 6 cycles of therapy and they push on so that, the patients are very wisely chosen, but that does not happen in the real world. And apart from that, the stage 3 and 4 and the performance status, if you look into, I think the ABVD arm had a little bit of patients who were more frail and rather than the one which was there in the echelon, though if you look into, they were not very significant, but there was a little bit of bias towards the patients whom they have chosen for the newer drug as compared to the ones in the conventional ABVD arm.
So in a randomized trial, I think that would be a real chance. It wouldn't be a bias because they have randomized the patients. But my skepticism always has been if they had used ABVD into 2 cycles and if the interim PET was negative and then they had continued without bleomycin in the control arm, maybe the toxicity that we have seen, and by and large it is pulmonary toxicity, which is higher in that arm. We could have had a better comparison of toxicities also.
Okay, you're telling, madam, like the way the Rathel was designed, if they could have done it
Yeah.
that way.
And we had enough information by the time this trial started. I'm not sure when it started, maybe we didn't, but I think that is something that I always criticize this trial for because their pulmonary toxicity is a little higher. Any thoughts on how much brentuximab should we give, or can we get away with a little less brentuximab?
Yes. Yes, madam, I feel so because, when we have used it for our patients, we have come down with when we look into the peripheral, mostly with the peripheral neuropathy. I have not decreased the dosage with febrile neutropenia or I've been a bit more liberal using Nukine or GCSF in these patients and try to push with the full dose of the brentuximab. But yes, with the peripheral neuropathy, we have come down to 0.8 milligram per kg, and still the patient have tolerated and completed the cycles without relapse. I will tell approximately 2 years have been the last follow-up. So I think we can come down with the dosage of the brentuximab also.
We have 2 questions before we wind up in the chat box. The first question is, for stage 1 and 2 unfavorable subset, would you recommend BV-AVD in the front line?
So if you look into the NCCN trial, the first stage 1 and 2, they are not suggesting for a BV upfront. It may be used, there is a consensus, but there is not grade 1A or higher recommendation, but there is a consensus you may use it if the patient has an unfavorable response. But as of now, for the lower risk or the lower stage disease, it is not advisable and it is not even approved. It is for the stage 3 and 4.
If you have a stage 2B, which is bulky, which is what we take almost as an advanced disease, will you recommend using brentuximab in those patients?
Madam, only if elderly, but if it is a young patient, I would still go ahead with the ABVD or a BFO.
The second question is, how many patients in clinical practice received radiotherapy, and how are the treatment outcomes in combined modality treatments in private practice? So you have to answer.
Yes, I will say regarding the same patient of actually PTCL. I have not used for the Hodgkin lymphoma patient radiation, but for the PTCL patient, if you look into for the elderly, there is also a maintenance of brentuximab, total of 16 doses, and it is very difficult if a patient is having a peripheral neuropathy to continue with 16 doses of brentuximab. So in that patient, we looking into the PET scan, there was limited stage when we assessed it. It was a stable disease with only abdominal lymph nodes. So in that patient, we have consolidated with radiation therapy, and then we have gone with the maintenance of the rituximab at a very low dose of 0.8 milligram per kg, and that was also monthly once based upon the tolerability. So you have to weigh the risk and benefit of giving a drug. It does not mean that you have always to you have to stick to the guidelines always, that this is the schedule and this is how it has to work, because it is ultimately how much the patient can tolerate and what is the amount of the drug which we can give to the patient. So their radiation therapy, I think, is a better way or a better option, and that gives us or buys us time to have some amount of reversibility of the peripheral neuropathy.
Most practical question is there, the last one. Do you stick to 1.2 milligrams per kg or round off to the nearest vial to avoid financial toxicities in your practice?
Yeah, we always try to wind it up so that we utilize the maximum of the vial which we are taking. It might be less, but we do not prefer to use more. So Hamesha it is like that.
Okay. Arun, I have one more suggestion. For patients who are body surface area more than 2, don't give them more than 150. And in some of these patients, if you give them very high doses, they get very intractable diabetes mellitus and end up in the ICU. So these are case reports, but I have seen one. And so I would only suggest that, be gentle with the doses, don't go too high. And there is evidence now in a retrospective analysis of, I think, the echelon, that even those who have taken brentuximab till about 4 cycles, the outcomes are not different. So whether it is 4, 5, or 6, when you look at the long-term outcomes, it is not too different. So if you are getting toxicity, please be assured that reducing brentuximab doses will not harm the outcomes of your patients. So thanks a lot, Priyanka, for a very interesting discussion. And I think we'll go on to the next talk by Abhijit.
Thank you,
Uh,
ma'am.
Abhijit is going to tell us how we can shorten. We always like to shorten treatments. And anybody who goes on to treatment doesn't like the idea of being on treatment for 6 months continuously. And anything to shorten. In stage 1 and 2, I think we have been very successful. But now it looks like we will be equally successful in late stage Hodgkin's lymphoma. So Dr. Abhijit from Apollo Hospital, Guwahati, Assam is going to speak to us on, can Hodgkin's lymphoma treatment be completed in 3 months? All yours, Abhijit.
Thank you, ma'am. Thank you. Can I share my slides, please? Sophia, you can share the slides.
Yes, sir. Just a second, sir.
Mhm. So yes, next slide. Yes, very good evening, everyone. So I'll be talking about, can Hodgkin's lymphoma treatment be completed in 3 months? So basically, I'll be talking about the advanced stage disease where where there is an option of completing the treatment in a 3 months period. We are living in an era of Instagram, WhatsApp, where everything goes in 10 seconds reel. So the patients are also very impatient nowadays. They want to get a very quick treatment, very early response. I have patients who are on ABVD, Hodgkin's lymphoma, and after like 3 cycles or 4 cycles, after 3-4 months of ABVD chemotherapy, they start asking, sir, whether we can stop the treatment. Some get infection, some get toothache. We have to extract the tooth. We have to delay the treatment. So now we are in the hurry to treat the patients within a very short period of time. Next slide, please. So this is a very interesting discussion by Dr. M.B. Agarwal sir in his session. So I have learned a lot from him. So can Hodgkin's lymphoma be treated in 3 months? The main question. And yes, for advanced stage disease also, we can treat, next slide. We can treat Hodgkin's lymphoma within a very short period of time, and it's possible. Next slide. So let's start with a case. So this is actually 29 years old male software engineer. So he has very high expectation in life, and he had a 3 months history of fever, night sweat, and significant weight loss. So he has definitely the B symptoms, and there is no significant past history. And he's recently married, and he's concerned about his family planning, preserving his fertility. And when we when the diagnostic workup was done, so he was found to have cervical and axillary lymph node, and ECOG performance status is 1. And he has a very elevated ESR with LDH within normal limit. And CCT thorax and abdomen was done, which is showing bulky intestinal mass. So 11 centimeter it is. And PET CT scan is showing stage 3 disease. So basically we have a diagnosis of stage 3 Hodgkin's, classical Hodgkin's lymphoma with B symptoms and with bulky disease. So histopathology has confirmed this type with obvious CD30 and CD15 positivity with PEX positivity. So when we do the risk assessment, it is a stage 3 in IPI, stage 3 disease, and the age is around 30 years. So we have a concern of preserving the fertility for this patient. So next slide, please. So this is an BRCA treatment that has recently been added, and this is a PET-guided treatment where we are assessing the efficacy and tolerability, and we are also assessing the non-inferiority of Bracard versus BACOP. We always have been using BACOP chemotherapy, the 21-day cycle for aggressive stage 2, stage 3 lymphomas, or in cases of ABVD lymphomas who are not showing very significant PET response after 2 cycles of chemotherapy. But now we are coming into the brentuximab era where will be using Bracard. Next slide. So this is a trial, HD21 trial, where they have randomized the patients, and the selection criteria is there 18 to 60 years, advanced stage Hodgkin's lymphoma, also including the stage 2 high tumor burden disease, then no prior treatment of Hodgkin's lymphoma, normal organ function, performance status is good, and no HIV history. And now they have given into 2 categories. One, the patients are receiving the BACOP or Bracard therapy, and initially they have been given 2 cycles of chemotherapy. Interim PET has been done, and if interim PET is negative, then they have been given additional 2 cycles. So after that, treatment is stopped. But if PET scan is positive, they have been given additional 4 cycles. And after that 4 cycles also, if the PET is negative, then we do follow-up. And if his PET is positive, we do consolidation radiation therapy to the targeted area. Next slide. So they have been taking up patients from all over the world, and you can see the comparison between the 2 chemotherapy regimen. What are the differences? So basically from BACOP, we are omitting the bleomycin. Basically, we are eliminating the lung toxicities. Then etoposide dose has been reduced, so that transfusion requirement, the hematological toxicity has come down. Doxorubicin dose is a bit mildly higher, it is 40 mg. Cyclophosphamide dose is almost same. Brentuximab has been added, whereas vincristine is removed. So neuropathy is not going to be a concern. Then most importantly, gonadal toxicity that is more associated with procarbazine, that has been removed from here. And prednisolone has been removed, where it is replaced by dacarbazine and dexamethasone. So basically, they are removing the gonadal toxicity. Neuropathy, I'll not say it's very less, because we are replacing one neurotoxic drug with another. But hematological toxicities are less because of the less of etoposide, and bleomycin has been removed. So next slide. So the primary outcome was the treatment-related morbidity. So with the Bracard treatment, it was shown to be 42%. With BACOP, it was 59%, and the relative risk is 0.7%. Next slide. Then second primary outcome was the progression-free survival. So we in these slides, we can see that with Bracard therapy, it is 94.3%. With BACOP, it is 90.6%. We can see that the hazard ratio is 0.6. So comparatively, a median follow-up of 48 months, Bracard is not only demonstrated non-inferiority, but actually showed superior progression-free survival compared to BACOP. Next slide. And when we compared about the PET response after 2 cycles, so you can see from the graph that 4 years PFS with 4 years progression-free survival with PET negative is around 96% with Bracard, and where it is 92%, with PET positive it is 90% and 87%. So overall, whatever our concept of being the PET negative, initial PET negative showing a greater response, whether it's a Bracard or BACOP, it is still persisting. But definitely for those patients who are PET negative, they have a very good progression-free survival, close to 95%, or it's 98%. Next slide. So when we forest chart, you can see in the right side, there's a PFS benefit. Definitely the PET negative Bracard, they're showing better response. After that comes the PET negative BACOP, after that PET positive Bracard, and after 2 cycles, after that PET positive BACOP. And when we see the response, that which are the patients who are more favorable for Bracard, those are the young patients, female, definitely, because elderly patient, they have toxicity, they're most probably not tolerating the treatment. Those are the female patients, and generally patients who are receiving 4 cycles of chemotherapy. Next slide. So secondary outcome, that was the overall survival. But when we compared these both two charts, basically there is no significant survival when it comes to the secondary outcome, that is the overall survival. So obviously PFS survival toxicity benefit is definitely there with breakout protocol, but overall survival remains same in both the protocols. Next slide. So secondary outcome. So one concern, what are our concern regarding the breakout of our BACOP is that preserving the fertility for in female patients, gonadal recovery was significant. And in male patients also, there is, compared to female, there is a significant advantage of breakout in cases of male patients. So preserving the ova, preserving the sperm was a concern for young patients while giving that BACOP protocol, but it has been significantly less with the breakout protocol. Next slide. So that has already been covered up, that grade 3 neutropenia, if you see, it's less with breakout, it's 30% to 59%. Thrombocytopenia is less. Leukopenia is almost same. The neutropenia is almost same. Neutropenic fever is same. So basically pancytopenia, that was very much common with BACOP, that was our concern, is relatively less. It's not very many, it's not negligible, but it's relatively less with that breakout compared to BACOP. Next slide. Regarding the dose reduction, the dose reduction is most frequently required in BACOP compared to breakout. The main reason is leukopenia and thrombocytopenia. As from our practical experience, we have seen it is around 32, 34 to 23 to 34% in cases of BACOP compared to the breakout. And full dose treatment up to 4 cycles was possible in around 78% of the breakout treatment. So it's not possible for all the patients. Most probably this is because of the neuropathy associated or the cytopenia associated with breakout. Yes, but compared to, if you compare with BACOP protocol, we can have a relatively less cytopenia where we can at least complete the 4 cycles and we can complete the whole treatment for advanced stage lymphoma within 3 months of period. Next slide. So secondary primary malignancies, which were very much which were a concern for the BACOP protocol. So when we compared both these protocols, so we can see there is not much significant difference. It's almost same. It's almost 1% converting to leukemia, MDS, not converting to and other non-Hodgkin's lymphoma. It is 1, but with time we have to see whether the cases are rising with breakout protocol, but till now the study seems showing same possibility of malignancies with both the regimes. Next slide. And so this is already been Priyanka already been mentioned that we are traveling through a history of ABVD. Initially, we are treating patients with ABVD, so toxicity become concerned, and we are going from that to the RRHL study where PET-guided treatment has been, de-escalation treatment has been put forward, where ABVD is de-escalated to AVD so that toxicities can be managed. Then comes the Echelon trial where they are showing that PFS benefit as well as the OS benefit with the addition of a novel agent. And now we are coming to the HD21 trial where definitely the advanced stage disease, which can be the good risk patients, which can be easily manifested, and treatment can be de-escalated or very minimum treatment can be given to this kind of patients. Next slide. So anthracycline exposure and long-term risk, I think that has been already been covered, because we know with the high exposure to anthracycline, that is more than 300 mg per meter square, is definitely associated with cardiotoxicity. And along with that, there's a risk of associated secondary malignancies. So here in the breakout protocol, after PET CT scan, if it is negative, then patient is only getting only 140, that's 40 into 4. So 140 milligram per meter square doxorubicin throughout the cycles. Whereas in breakout, we are generally giving 6 cycles. So considering that, we are actually giving 240 milligram per meter square. And ABVD based protocol, we are actually giving 300 milligram per meter square. So when you compare that PET-based treatment approach and for high-risk patients, high stage 3, stage 4 patients, so Breakard is going to give less exposure to the anthracycline group of drug. Next slide. So study strength that has been mentioned, they have mentioned that they have a reverse study design. They have taken around 1,500 enrolled patients over different categories, and they have been reviewed centrally, and worldwide data has been taken. But I'd very like to see Indian scenario, because that brentuximab dose that has been given 1.8 milligram per meter square, and secondary what toxicities they are going to have in Indian setting, and the treatment response, like after 2 cycles of Breakard therapy, what the PET response is going to show in Indian setting, that will be going to very interesting to see. That will definitely come in next few years. The data will definitely come in next few years. Next slide. So so the key advantages, what we are going to discuss is superior efficacy, because unprecedented 4 years PFS is around 94%. Basically, it is very good considering cases of advanced Hodgkin's lymphoma. Then tolerability, if we are saying the treatment-related morbidity is less, 42% compared to the 59% in considering the BA-COP. Then preserving fertility, especially in young males, as well as in female cases, it's showing very good data. And short treatment duration, because after 4 cycles of treatment, there is a possibility that we can stop the treatment. If after 2 cycles PET is negative, we have a scope that after 4 cycles, like after 3 months, we can completely stop the treatment for advanced Hodgkin's lymphoma. Next slide. So NCCN guideline also, they have incorporated Breakard treatment plus GCSF, obviously, because these patients go into neutropenia. They are, though it's less than BA-COP, but still there is a chances of neutropenia. So GCSF support will be needed. And in after PET CT scan, ISRT plus minus, that has been included for bulky disease, that is clinician-based treatment. So next slide. So in summary, if we have to say, the Breakard is significantly better tolerated than BA-COP, and recovery treatment-related morbidity after 12 months is more in 99% of the patients. Improve feasibility up to 25% higher than the full dose. Efficacy-wise, PFS advantage is around 94%. 4 cycles is enough for the patient. Doxycycline or anthracycline toxicity is going to be less, because less dose is going to be used, and individualized PET-2 guided treatment will be needed, because after the 2 cycles of chemotherapy, what the PET response is showing, based on that, we have to decide the treatment for this kind of patients. So next slide. I think we are finished. So to be practical, yes, back to Reena ma'am. Yes, ma'am, actually to be practical, I have not used Breakard till now. So whatever data is showing, I am just presenting those data. Yes, I have used brentuximab upfront settings in Hodgkin's lymphoma patients, but upfront for definitely for stage 4 diseases, because what my experience over last 7-8 years is that though we are telling that Hodgkin's is very curable, I have seen patients relapsing with stage 3, stage 4. So now I have now that is my personal experience, a gut feeling like advanced stage bulky disease stage 4 should be treated with brentuximab based treatment, as data has been showing. But stage 1 and 2 definitely not. And for elderly patient, I'll still be reluctant. I'll be always in the back foot while using brentuximab, but because I have seen patients are not tolerating after 3rd or 4th cycle, severe neutropenia, have to stop everything for next 3 to 4 months. So those experiences are also there. So, and one case of ALK positive ALCL, recently I have treated a boy because CD30 was positive after 2 cycles of CHOEP. So refractory disease, lymph nodes are reappearing after 21 days or 15 days. So I get fed up. I have to use brentuximab. There's a very good molecule showing very good response after 2 cycles. So after 2 cycles, we are planning for 2 more cycles followed by an autologous transplant. So definitely the brentuximab, in my opinion, is a very good drug, but we have to use it very cautiously, very carefully for selected case of patients. Thank you, ma'am. Back to you.
Thanks, Abhijit. I won't be able to give you too much time for discussion, but a question or two in the chat box will encourage all the speakers. And in the meantime, I'll just ask you, when we did the Echelon 1, they did the PET analysis as guided therapy, but they did not change the treatment depending on PET. The reason being, when we
Yes,
use
ma'am.
drugs like brentuximab and the checkpoint inhibitors, you may have inflammation, and that doesn't really
Yes,
mean
ma'am.
that there is disease. So what will you do to say that this is truly PET, the PET positivity is not disease? Will you biopsy all the patients, or will you just go ahead with the standard that they have recommended? That means 4 dose, in which case post the PET positivity, which means we are actually not going to be able to reduce the treatment in almost 40% of the patients. And the outcomes are
Yes, ma'am. That is
excellent. We are
actually
seeing,
challenge.
outcomes at 98% overall survival and beyond 95%. So what will be your recommendation if you were using BRCAD? You have PET positivity at the end of 2 cycles. Will you just go ahead with 4 cycles, or will you try to prove whether there is disease or not, and then actually be able to reduce the treatment in another 20 to 30% of the patients?
Ma'am, there comes the challenge. Actually, breakout with I've read actually I've gone through that study. So that is the problem there. Ideally, if you have confusion, you should prove it by biopsy. So that should be done. So you have, if you have but you that convincing the patient that that uptake is not because of the disease, that is because of the disease inflammation process. It's very difficult, ma'am. So what I feel at the very end will be dealing with a 6 cycles of breaker, whatever the study says or whatever the thing says. And in that scenario, we will be trapped with the problem with neuropathy again, because up to 4 cycles may be possible for a patient, but up to 6 cycles, I don't know how many Indian patients will tolerate that thing. So that will be a trap we are actually building for ourselves, because after that, we have to prove that it's biopsy proven, that it's not disease related. And if we are not doing that, then to be safer side, we'll be playing a 6 cycles breaker treatment.
Yes.
I don't know.
So
I don't have that answer till now, ma'am.
No, I agree completely with you. And so the caution will be, it is more of a breaking statement or breaking news that we can finish in 3 months, but we'll have to be cautious because there will be false positive PETs, not only the true positive PETs, but false positive PETs. And many of these patients will actually get the full treatment, which will not be able to, we will not be able to actually reduce treatments. Okay, so I see an empty chat box, but please feel free to ask questions. We will have another question and answer session also, and all of you can ask questions at that time. So thank you, Abhijit, sorry. And we'll go on to the next presentation, which is by Dr. Debmalya, and he will speak on refractory Hodgkin's lymphomas, relapsed and refractory Hodgkin's lymphoma. And I think he'll do a case presentation and then tell us where we can use brentuximab in this cohort of patients. Dr. Debmalya is from Apollo Hospital, Kolkata. And Dr. Debmalya, you can start now.
Thank you, ma'am, for your nice introduction. So, just a second. Yeah, is it visible?
Yes, sir.
Yeah.
Yeah, we can see your slides. You can put it into your slideshow mode.
Yeah. So, thank you, ma'am. So, I'll just present a real case of mine. So, this patient is one of my friend's uncle. So, it's a very difficult case for me to treat. So, the patient, he was 63 years old gentleman. Intermittent high fever with lymphadenopathy with no first history of TB. He came to our OPD. So So and no past history. Initially, he went to one of my colleague, who is a pulmonologist. So he thought that it's a tuberculosis by clinic because there was some family history of tuberculosis. So, but Rukat biopsy was done. It showed that it is a classical Hodgkin's lymphoma, CD1530 positive. So patient was not satisfied with the counseling and treatment plan. So they went to TMH Mumbai at the very beginning. So their rebiopsy and IAC was again done, reconfirmed to be classical Hodgkin's lymphoma stage 4 with bone marrow involvement in the PET scan. So they were advised AEVD protocol, 2 cycles of AEVD protocol followed by interim assessment. So I just followed the protocol given by the TMH Mumbai. Then the patient came to me and told me to follow this protocol only. So initially 2 cycles of AVD began. Every cycle patient developed, first cycle patient developed severe cytopenia, febrile neutropenia, admitted into the ICU for a brief period. So in the second cycle, dose of doxorubicin was modified to 60%. So after 2 cycles PET CT scan done, it showed progressive disease on PET CT, new lesions in the spleen and bones. So that time it was a very difficult point for me, because family thought that it is, as I reduced the doxorubicin dose by 40%, so it is a reason of failure. So then they went to TMH Mumbai again, and there they advised continuation of the therapy. But at this point of time, someone in the family, he told, now the therapy should be checked. So there is a lots of chaos with this patient. So I did a rebiopsy from the new lesion in the iliac bone. It showed again the classic Hodgkin's lymphoma. Then after much discussions, literature review by the patient's family, everything, they opted for immunotherapy. So brentuximab was decided, and I gave 2 cycles of brentuximab and bendamustine. So in October 2023, he raised the 2 cycles of brentuximab bendamustine. He achieved complete metabolic response, and he was 63 years old then, and he was not willing for auto transplant, and all other options were explained to them because they have already done the literature review on their own. It was very easy on my part to explain them the options. So then we planned for the brentuximab maintenance, tolerating well. Fourth dose completed in March 2024. Everything was normal, and patient gained weight. Everything was fine in their life. And again, stem cell transplant I discussed, and they were not willing. Now after post fourth dose of maintenance of brentuximab, he developed burning sensation over the feet, and it was documented by NCB that they had a neuropathy. So brentuximab was stopped, and then reassessed in PET CT scan in July 2024. It was reactive type of PET scan, mostly in remission. So no definite new lesions has appeared. So patient was planned for close observation and kept off therapy. Now the patient lost to follow up. He again came to May 2025. I advised them for PET CT scan. So they told, okay, we'll do, but the hemoglobin, CBC, everything, LDH, patient symptoms, everything was normal. But he came to me again with my advice of PET CT scan, which was in May, in August this month only. So now they agreed to do a PET CT scan. Still patient has no symptoms. He has gained more weight, more 2 kg more than May 2025, and no symptoms. But still they did the PET CT scan. At last PET CT scan was just 1 year back. So this time the PET CT scan, it revealed relapsed lymphoma following multiple FDG avid lymph nodes above and below diaphragm, and again few bone marrow deposits. So it is again a stage 4 disease. And this time the patient is not agreeing for rebiopsy. They are telling that you continue treatment with brentuximab as long as our understanding. Now our current plan, what should be? Counsel for poor risk options are BV-ABD, again BV bendamustine, or Nivo-ABD, and reassess after PET CT scan. And lastly, the patient opted for BV-ABD. I have not convinced them for any plan, but this is the scenario right now. I have not started therapy yet, so it was a great opportunity for me to place this case in front of Reena ma'am and others, that what should be our strategy in this particular patient. So this is the summary. Classical Hodgkin's lymphoma stage 4, a failed AEVD, progressive, responded to brentuximab bendamustine 2 cycles, achieved CMR, then he was in remission, received 4 maintenance brentuximab, then lost to follow-up for 1 year, then again relapse into after one and a half, around 18 months, 1.5 years, and now plan for the next treatment. Family willing for brentuximab only.
So yeah, the patients, I think, who decide treatments for themselves are always difficult to treat. They
I
belong
agree,
to
ma'am.
your known jurisdiction. So
There are 2 or 3 doctors in the family. So
yeah,
this is,
that becomes even more difficult. And now with AI and all the information available, it's not going to be easy for the new generation to treat patients. But having said that, there is enough documentation now that actually, if somebody relapses and the relapse is about a year later, earlier the teaching was that you give them combination chemotherapy or targeted therapy with chemotherapy and take them for an autologous transplant, and that would give you the best results. There are clinical trials now in which they are giving brentuximab and nivolumab for about a year, and the trials are on to see if we can slowly get away from auto transplants in these patients. So that is one combination available for people who are extremely rich because the financial toxicity is huge. In this patient, I think it's a good idea to put the patient into some kind of remission, even if you use the older chemotherapy drugs, because he's had a reasonable remission. So whether
yes.
it is brentuximab GDP or brentuximab with some kind of truncated ice, you can put the patient into remission, and then he may not be able to take too much of brentuximab as maintenance later on. So this time complete all 6 cycles of chemotherapy, because for all transplant ineligible patients, it is better not to stop therapy earlier than all the standard cycles of chemotherapy have been given. So in the last round of treatment also, if they had refused transplant, maybe we could have completed all 6 cycles of therapy and then kept them under observation. I'm not saying that for certain the PFS would have been better, but there is always a chance that we get a better PFS if we've completed standard number of cycles of therapy. So that is one approach. And there are many senior people in the chat box. So if some of you have any thoughts on this case to help Debmalya handle his patient and the family, please feel free to join us in
Yeah,
the chat box.
I need others input, because in such cases, I initially told them to go for this nivolumab, you can go, but he had a response with, as ma'am, you agreed that he has a good response with brentuximab, so it may work.
Yeah.
But again, the chance of neuropathy is there.
So yes, we don't have any question, any more help. Priyanka, will you like to come up with some suggestions for
Yeah.
Debmalya?
Yeah, madam, this patient actually, he said that initially there was a neuropathy. I have seen bad neuropathy with BB, even though the response is good. I think either you can re-challenge with BB, but I think Nivo is also not bad an option, because you have got very good results with Nivo in the
Yes.
95%, 98%. I think it's amazing. And the drug is quite tolerable, apart from the fact that you may have some autoimmune manifestations, which definitely are being taken care of by steroids. But I think, as per Nivo, I have used Nivo in much of our patients. It is more tolerable than brentuximab.
Yeah, and the cost is cheaper. Which dose you are using, ma'am?
Now, your patient is very affording, you see. He himself is asking for brentuximab. But looking into the overall profile, I find that Nivo is also having very encouraging results. And as madam said, definitely brentuximab and Nivo now, the maintenance is very good with it.
And ma'am, what is Rina ma'am, what dose you use? Somebody uses 40, some 100, some 140. Which is your practice?
For practice for Nivo.
Nivo dosing?
Yeah, I think 140 is what is the standard recommendation.
And gap
among
3
the-
weeks or 1 month, what do you follow actually?
So that depends. If I'm using Nivo with AVD, then it is every 15 days.
Hmm.
Yeah. And if I'm using it in in a setting where it is as a salvage before we take them up for auto, then it is Nivo Ice, which will be 3 weekly. And uh, and if you're using brentuximab and Nivo, you can give it together. And I think there is enough evidence to show us excellent results at 3 years if we have given the two in combination. That is generally 3 to 4 weekly. So the toxicity of brentuximab, especially peripheral neuropathy, definitely comes down if we are using it with a larger interval rather than every 15 days. So we now have some questions. Even some patients do not require transplant if you use, I agree. There is one more. Pembro GVD study showed 5 patients without transplant doing well and safe. Yeah, the new recommendations seem to be that in Hodgkin's disease, we will get away from auto transplant at some point of time, and we will be using targeted therapies together or targeted therapies with chemotherapy and then followed by maintenance for at least a year. And if patients can tolerate that, perhaps high dose chemotherapy will be something of the past in at least the first relapse in patients of Hodgkin's lymphoma. So, any other questions to the speakers so far, or general questions on lymphoma can be put into the chat box. I still have 3 more minutes before we go on to the next presentation, which is the ICML abstracts of 2025. Okay, so thank you very much to all the three speakers. And now we can go on to the next part of this presentation, which my colleague Dr. Shouriyo will do for all of us. And he will be discussing the Frontline Hodgkins Lymphoma ICML abstracts of 2025. Dr. Shouriyo is one of our very bright consultants at my own institute, that is the Tata Medical Center. Shouriyo, you can start.
Good evening, ma'am. Thank you so much. Good evening, everybody. Am I audible? And is the screen visible?
Yeah, we can see the screen, and maybe if you come a little closer, we'll be able to hear you also a little better.
Okay. Is it better now?
Yeah, yeah.
And is it in full screen mode? Sorry, I'm just checking. Is it in full screen mode?
No, sir. Sir, if you can put it into presentation mode.
Just a sec. Is that better?
Yes, sir.
Perfect. Yeah, go ahead.
Okay. So good evening, everybody. So I'll be discussing a patient whom we all treated at Tata Medical Center with brentuximab use in upfront setting in case of Hodgkin lymphoma, and then we'll see an interesting abstract which was presented. So this is a 35-year-old young gentleman from Bhutan who presented with a 5-month history of constitutional symptoms and pain. So he had a fever with chills and evening rise of temperature, unexplained weight loss of 7 kgs over 5 months, and left supraclavicular swelling of 2 months duration. He had no comorbidities, and he's a driver by occupation and a father of 2. So in the physical exam, he had a large left supraclavicular lymph node mass palpable, a conglomerated mass about 5 into 3 centimeter size. He had no other lymphadenopathy elsewhere in the body and no organomegaly or any systemic abnormalities. These were his counts. WBC of 9,800, hemoglobin 15, platelet count normal, LDH slightly on the higher side, our cutoff is 246, and ESR was elevated. So we did a biopsy from the supraclavicular lymph nodal mass, which confirmed the diagnosis of classical Hodgkin lymphoma. And imaging was done after that, and it showed extensive disease with multiple nodes enlarged. He had a lot of retroperitoneal lymphadenopathy. He had splenic lesions. He also had bone marrow uptake. You can see the PET scan here showing bone marrow, diffuse bone marrow uptake, splenic lesions, also supraclavicular and mediastinal lymphadenopathy and retroperitoneal lymphadenopathy. So this was a patient of stage 4B classical Hodgkin's lymphoma with bone marrow and splenic involvement. So the initial treatment, we started with brentuximab and ABD after performing the organ function assessments. So this was the PET scan after 2 cycles, and you can see that there's almost near complete resolution of all the nodal disease, also the marrow disease. And the PET was reported as dual 4 because there was some mildly hypermetabolic retroperitoneal and common iliac nodes still seen on the scan. So we continued with another 2 cycles of BV ABD and repeated so there were also some adverse events noted by now. So he had developed neuropathy. So what we did was, instead of taking away the brentuximab, we substituted etoposide in place of vinblastine. And after that, this was the end of treatment scan. So after 6 cycles of BV-ABD and then subsequently BV-AED, this was the end of treatment scan. You can see that he was in complete metabolic remission. And so he had healed disease. So he's about 1 year post-treatment and maintaining the remission, and he's doing well. Neuropathy is, he had some neuropathy initially that he's kind of, it's resolved to an extent, and he does not have any limitations of activities of daily living. So this basically shows the use of BV-ABD in the upfront setting, and with the expected toxicity of neuropathy, and we mitigated by a slightly different approach, and found good results. So I'll go over this abstract, which was by the Italian group. Basically, this is a real-world study of using BV-ABD in upfront treatment of Hodgkin's lymphoma. So this is an Italian real-life multicentric study. So what they did was, it's a retrospective multicenter study where 137 patients treated with BV-ABD and 92 patients treated with ABVD. All were stage 4 disease. These were compared. So this was after Italy got approval for using brentuximab in frontline treatment of Hodgkin's. So the primary objectives were they evaluated peripheral neuropathy, and secondary objectives were progression-free survival, CR rates, dose modifications, and infection rates. And they used interim and end of treatment scans to evaluate efficacy. So the CR rates were 90% with BV-ABD compared to 87% with ABVD. This was at the final PET evaluation. This was not statistically significant. There were significantly fewer events in the BV-ABD arm as compared to the ABVD arm. And 1 year PFS was better with BV-ABD compared to ABVD, but this was also not statistically significant. And the interim PET was showed significant predictive value for survival in the PET negativity showed predictive value for survival in the BV plus AVD group. In terms of peripheral neuropathy, there was, as expected, higher incidence of peripheral neuropathy, 46% versus 14% in the BV-AVD group as compared to ABVD. And neutropenia and infections were similar. There were more frequent delays and dose adjustments in the BV-AVD group, 33% versus 26%, primarily due to peripheral neuropathy. but dose delays and dose adjustments were more common in the BV-AVD group. So they concluded by saying that it has high efficacy with comparable CR and CR rates, but with slightly better progression-free survival as compared to ABVD. Here, all the patients were stage 4 disease. So this was the PFS curve. You can see the blue line on the left is that with brentuximab AVD, and the red line over here is with ABVD, 91 versus 80%. So yeah, so neuropathy is a significant concern, happens to all the patients. What we have seen is that about 8 or 9 doses into brentuximab, the neuropathy starts happening. It starts affecting the patient's quality of life. And if you take off the drug then, or if you reduce the dose, or don't use other agents which cause neuropathy along with the drug, it can be mitigated, and to an extent there is a reversal of the neuropathy as well.
So thanks, Shouriyo. Now we are really open to questions, and I think all the speakers can come online, and I look forward to questions in the chat box because we still have some time. We have about 15 minutes to go. So while, okay, Arun is here and he has a question with access to Nivo and BV in our country and their utility in both upfront patients in frontline and relapsed refractory setting. How would you counsel patients between ABVD, BV, and checkpoint inhibitors in frontline? Shouriyo, you can take.
Yes, ma'am. So I'll take this question, ma'am. So I mean, even day before yesterday, there was this new patient of Hodgkin's lymphoma, and I had to do this exact same job. So basically, I wrote down on a piece of paper ABVD, and after getting the staging information, this patient in question was also stage 4. So I wrote down the costs on one side, and I wrote down the outcomes on the other side. And then I let the patient choose. Basically, ABVD, this is the cost over 6 months. This is the outcomes. This is the cost with brentuximab AVD, and these are the outcomes. And this is with Nivo AVD and the outcomes. Also, the side effects, I briefly touched upon them, but that is too much of information for the patients if they have to compare the choice of regimen with response rates and side effects as well. Primarily, I focused on the cost and the response rates. So that is one way, but it's a close call between brentuximab and nivolumab. And practically, ma'am, we have seen a lot of dose limiting and I would say quality of life hampering neuropathy side effects with brentuximab. Whereas Nivo, in my limited experience of using Nivo in frontline Hodgkins, they do pretty well. I gave it to a very elderly anesthesiologist. Initially, there was some anemia. I looked up, searched the literature for anemia due to nivolumab. Didn't find much on it. Thought whether it could be some autoimmune kind of anemia or autoimmune myelosuppression of some sort. But then after completing 6 months, he's doing fine. No further autoimmune side effects. Anemia has also recovered. So practically, I think Nivo is an easier drug to use if there are no abnormal side effects. We have seen a few patients getting horrendous neurological side effects, like the patient who developed myoclonus prior to transplant and eventually had a whole lot of neurological complications post-transplant. He was Nivo exposed prior to transplant. Then we've seen a lot of autoimmune thyroiditis in a few patients. Also, when it occurs, the autoimmune side effects of nivolumab are pretty bad. But I think the percentage is less, whereas neuropathy with brentuximab will happen to everybody.
Yeah, I think I completely agree with Shouriyo that if we look at 75% of our patients, when you put the cost, immediately they're happy to go ahead with ABVD. And sometimes in oncology, you have to bear costs in mind, especially in a disease like Hodgkin's, where we know that the second line is almost equally curative in most of the patients. And so really to expose 100% of the patients to such expensive drugs is going to be difficult with unless we become a real superpower and we become the best in the world, right? So for now, I think the standard treatment, whether we like to say it or not, is going to remain ABVD. And it is going to, for patients who go into remission, I think the RRHL trial is the best to reduce toxicities. And it's almost like patients come in and go out of the OPD without any toxicities. I don't remember when I really admitted an ABVD patient for a serious adverse event. Brentuximab invariably, even in the young patients, has a lot of toxicity. And if we don't take it seriously or we neglect it for any reason initially, just trying to complete the number of cycles, we have ended up with grade 4 peripheral neuropathy, which is foot drop and, whatever wrist drop, and eventually the patient being on a wheelchair for about 3 months. So I am actually scared once the neuropathy starts, please rethink about continuing brentuximab in these patients. Nivo has been much easier, like Shouriyo has just said. It is easy to give, but I think we still need the long-term results. We have the initial results, and it is almost as good as brentuximab and AVD in terms of responses and progression-free survival that we see with a little advantage in the initial progression-free survival for Nivo rather than brentuximab. So coming to relapsed refractory disease, I think it entirely again depends on the financial ability of the patients. Having said that, just 3 cycles of brentuximab with bendamustine are very easily tolerated by most patients. And we see really high response rates to these 2 to 3 cycles, unlike what we see with platinum-based or gemcite-based combination without these targeted molecules. So just 2 or 3 cycles and take them for auto transplant, I think is still more reasonable and financially less toxic than continuing these therapies for what is recommended as combination for 1 year. That is actually much, much more expensive than doing an auto transplant. And then, of course, if the patient relapses again, you can use the other molecule with an other chemotherapy combination to put them into remission and go ahead with an allogenic transplant, taking care that after Nivo, you have to give them enough time before you take them for an allogenic transplant. Priyanka, Abhijit, any more questions, any more comments from your end, or any questions that the audience may have? Please put it into the chat box.
Madam, I just wanted your opinion regarding a patient of ours presently. He's 70-year-old male, stage 2B bulky disease. And we started with ABVD. First cycle, day 15, he is due for. And he has an ANC of 250, never had any infections. So in the induction of this first cycle, should I wait for the counts to recover a bit and then proceed looking into the age of the patient, or should I continue with ABVD as per the day 15 dosage and the full dosage?
So 250 ANC is really very low.
Yeah.
Yeah, I wouldn't take a chance over there. So when we give ABVD in younger patients, if your ANC is at 800,000, we normally give 1 cycle of growth mucine and try to see what the counts are in 2 days' time. And invariably, if the young patients have good reserves, the counts come up. So you don't give too much of growth factors, which you are worried with bleomycin, and yet, to feel comfortable, your counts easily come up with 1 or 2 shots of GCSF. And then you go ahead with the doses. At 70, I would be reluctant to give prolonged growth factors with bleomycin. and at the same time to give the dose so close by. So you can give 2 or 3 cycles of Nuca and see how the counts are going up, and then accordingly plan the dose. I think you'll have to come down on his doses also. The full dose of ABVD is something that is going to be dangerous to this patient. And there is some, I won't say evidence, but there is some suggestions that if you give these patients 3 cycles of Nivo upfront and then sequentially give them AVD, the outcomes are the same. Older patients treat their or they tolerate their treatments much better. And by the time you finish 3 cycles, quite a lot of them are already in remission. And once they're in remission, giving the chemotherapy becomes much more easier. For patients at 70, I'm always worried about bleomycin. And if earlier we used to use etoposide as a drug instead of bleomycin, the AEVD regimen which Debmalya was showing us from TMH. But adriamycin and etoposide together also are pretty myelotoxic. So we have to be a little careful over there. So if we really can't afford any of these new targeted molecules, then I think we'll have to reduce the doses of ABVD. But for a check, you can just give 1 or 2 shots of GCSF and see what his bone marrow reserves are like.
Thank you, ma'am.
So I think we've had a lot of discussion, and if there are no further questions, I'll hand over back to the hosts of today. Sophia, you can take over.